Welcome, everyone, to the ALS United Mid-Atlantic Goals podcast. My name is Tony, and I am your typical host of this podcast. But today, I'm very excited because my friend and colleague, Alisa Brownlee, is going to be the host of the podcast. Alisa has over 25 years of experience supporting the ALS community. She helps lead our assistive technology program, and it helps people with quality of life, and is very active in our ALS clinics. Today, Alisa is going to be talking with Stephanie from the Thomas Jefferson University Jefferson Weinberg Center. They'll be talking about nutrition and ALS, and it's a terrific discussion that I think will be important to anyone who is impacted by ALS. I hope you learn a lot, and thank you so much to Alisa for hosting this episode. I encourage you to follow, like, and subscribe so you can get more updates on this podcast. And I think that Alisa will end up hosting some more podcasts in the future to share her expertise and hear from other leaders in the ALS research and care field. Thank you so much, and enjoy.
Hi, I'm Alisa Brownlee with the ALS United Mid-Atlantic office, and I have the privilege of interviewing my colleague, Stephanie Dobak, who works at the Jefferson Weinberg ALS Center, and I am going to let her do her own introduction and tell you what she does.
All right. Thanks, Alisa. Again, my name is Stephanie Dobak. I'm a clinical dietitian at the Jefferson Weinberg ALS Center in Philadelphia. This is part of a multidisciplinary clinic, and I can't stress the importance of trying to get to a clinic if you can. These clinics are one-stop shops, I think, is the best explanation for them. So you don't have to make separate appointments. When you have an appointment at the clinic, you can see a neurologist, another provider, usually a nurse practitioner. We have pulmonologist, respiratory therapist, physical therapist, occupational therapist, speech therapist, registered dietitian, palliative care providers, research teams. We work with the ALS United Mid-Atlantic to have social workers and mental health nurse. So I hope I'm not forgetting anybody. Oh, a genetics counselor. So I love the clinic because we all work together to really collaborate together and make sure that your plan makes sense for you and that we're not going against each other with our individual plans. So I'm happy to be here today, and thanks for inviting me, Alisa.
Oh, you're welcome. And every clinic or center is different. Some centers will have other disciplines that you didn't mention and others won't, but I think what, at least for me, what makes Jefferson unique is our research arm. We have researchers as part of our team because I think a lot of our people diagnosed with ALS, they want to know what's out in the research world. And
Yeah,
I sure tell them that. So every person, if possible, we encourage them to go to a center, but we understand that some people can't get there. They're too far. Thankfully, we do have telehealth now, so hopefully people with ALS can get the help they need. And one of the things they need to know is things about what kind of food to eat. And so can you explain what a dietitian does in terms of helping a person with ALS manage their disease?
Yeah, and first, what is a dietitian, and is it the same as nutritionist? So I really wish there was an easier answer to that question. So this term nutritionist is a very loose term. It can be applied to anyone interested in nutrition. So this includes your online influencers. It includes your gym bros. They can call themselves nutritionists technically. It doesn't require any formal training. However, there are certified nutrition specialists or CNS, certified clinical nutritionists or CCNs who do have formal education. I will say at most ALS clinics with a nutrition expert, you're going to have a registered dietitian. Some opt to go by registered dietitian nutritionist. In the US, as of 2024, this degree requires a master's degree. It requires an internship with supervised practice experience. It requires them passing a board exam. You have to complete continuing education every year. So, along with the certified nutrition specialist, certified clinical nutritionist, the registered dietitian or registered dietitian nutritionist have extensive formal training. So I know that's as clear as mud, but in essence, if you are looking for nutrition advice,
Yeah.
look for those titles that have certified or registered in them, because anybody without the formal education cannot use those terms to call themselves a certified nutritionist or registered nutritionist or dietitian.
Great. So
So
don't
what do we do?
go on social media and go, hey, I found a nutritionist. You want to look for somebody with your background and somebody who
Yes.
has an education in dietitian management. Is that a good word?
Yeah, it just like have the credentials, have the formal training.
Yeah.
Because you can get some wackos out there, unfortunately, with any sort of area of expertise. But so what do we do?
Yeah.
Especially for people with ALS, we do a lot. We conduct these nutrition assessments. So we're going to see where you are nutritionally. We'll ask about weight history. Have you lost weight? Have you gained weight? What do you typically eat in a day? How's your appetite? We're going to identify any barriers to eating enough food. And we're going to review your medications, your lab values. We might poke a prod around at you and perform a nutrition focused physical exam. So, looking for any fat loss or muscle loss that might be related to your nutrition intake. We offer advice on getting pals to get enough nutrition and calories in to maintain their weight and be overall nutritionally sound. Again, if we're working at these clinics, we're going to work with other members of the healthcare team to see how their specialties are impacting our nutrition plan. So if there are swallowing difficulties, we're going to get the speech language pathologist involved. If there are problems with self-feeding or accessing food, we're going to get our physical therapist or occupational therapist involved. A lot of PALs, the studies show at least 70% of them experiment with dietary supplements. So we'll talk about supplements. Most dietitians are very passionate about bowels. We know that constipation is a common side effect of ALS. So we will talk about your bowels, bowel habits, and help manage that. Some dietitians are involved in nutrition research. So we might ask you to enroll in our studies. And then we often had that hard discussion, about if a feeding tube is beneficial or desired by PALs. And for those who do opt to get the feeding tube, the dietitian manages what goes into the tube. At some ALS centers, the dietitian will be in charge of ordering supplies for the tube. They might swap out the tube when needed, troubleshoot any issues associated with the tube. So this is not an all-inclusive list, but it gives you an idea of what dietitians do in ALS clinics.
Yeah. And can you talk about why is it so important to maintain your nutrition? What does it do to the body, or why is weight maintenance important?
Yeah, so there's really this direct relationship between weight and survival in ALS. So the more weight you lose, the less survival time. So this is likely, we don't really know the full effect of why there's this association, but we think it's because when you lose weight, we would love for it to be in that problem area, that fat area, like our belly fat. But the truth is the body needs energy, and that energy comes from food. It comes from calories. If you're not getting enough calories in, your body still needs energy. So it goes to the stores. It goes to the fat stores, but it also goes to the muscle stores. So it breaks down fat and muscle to get energy. With ALS, we know the body is going to be losing muscle mass as part of the disease process. But if you're not taking in enough calories and your body is breaking down muscle mass for energy, that expedites the muscle loss process and that advances the disease quicker, and that leads to a shorter survival time. So that's why we want to avoid weight loss at all costs, because it's associated with muscle loss and decreased survival. And this is where I become the fan favorite at our clinic, is that studies show that people with more weight on them live longer. So for our general public, we want a BMI, this body mass index, this calculation of height and weight. We want the BMI to be in a range of 18.5 to 25 for the non-ALS population. The definition for obesity from BMI starts at 30. So we know that in the non-ALS population, that obesity is associated with negative things. It's associated with cardiovascular disease and diabetes and some cancers. But studies in PALS show that a BMI of 30 to 35, so that obesity range, it's actually the sweet spot for survival. So we call this obesity paradox. It doesn't even make sense. So if you start the disease process with that BMI of 30 to 35, we try to keep you in that range. If you're under that range, we might ask you to gain a little bit weight. But the goal above all else is to prevent weight loss.
So I know, like, if you said to me, "Oh, Alisa, increase your calories," I'd increase my protein, right? Isn't that what normal people go? But that's not necessarily the case with people diagnosed with ALS.
Yeah, and I mean, I feel like it makes sense because we associate protein with muscle,
Yep.
and interestingly, to my knowledge, we don't have studies looking at the protein requirements for PALS. I will say in past surveys that we've done for nutrition professionals, we ask, what are you recommending for protein goals? And on average, they recommend in that range of about 1 gram per kilogram of body weight. So that's about in pounds, about half your weight. So if you're 150 pounds, we're probably going to recommend in that get about 75 grams of protein per day. But really, that is just an educated guess. Again, we definitely know that inadequate calories and weight loss is detrimental, but we're unsure at this point if more protein is better. But I always say, watch out for sneaky marketing. So many of our pals go to shakes to get extra calories in. And a lot of these shakes will be marketed as high protein. And it's like, great, we need protein. We're losing our muscles. But generally, the high protein ones are low in calories. They might be 150, 180 calories per bottle. And these are really targeted at bodybuilders, people that are working out who need the protein post workout to recover the muscles and repair the muscles. But these don't necessarily have enough calories for PALS. So if you're buying these types of drinks, I encourage you to find ones that have at least 300 calories per 8 ounces so you can get in the calories. They usually have adequate protein. So we just focus on getting enough protein, but not going crazy in that area. But really, we try to emphasize the calories until we have enough evidence saying that we need to do more protein otherwise.
Yes. So it's about calories, not necessarily, oh, okay, I need, like you said, X amount of protein. So one of the old dietitians I used to work with said, I'm so lucky. I tell you to eat Haagen-Dazs and I tell you to put butter on things. But for somebody who has watched their intake their whole life, this can be a difficult transition, right?
It really is. And especially when we tell you we want you to gain weight, and it's just like, and we'll talk about later, just like, I do care what you eat, but at the end of the day, I want you to maintain that weight. So it's hard. It's everything that we've told you not to do. I'm like, I want you to eat that now.
Yeah. Yeah. And we are going to break this up into two segments. So I'm going to ask you the last question, and then we'll go to part two. So the last question is, you're telling me to eat, and I have this full plate, but I'm taking an hour to eat. Is like, what should people look for when they're trying to eat all these calories, but it's taking so long?
Yeah, and I really think it depends on how you eat at baseline. So I'm a fast eater. I can hoover an entire meal in 5 to 7 minutes, but other people actually take time to chew their food and swallow. So they might take 20 minutes. But I say if you are taking 2 to 3 times your average, or if you're taking more than 45 minutes per meal, that is too long. It indicates that there's a problem, and you need to bring it up to your healthcare team. So what are the options? Again, we say to eat more calories. So there's some research suggesting that a low inflammatory, kind of like a Mediterranean style type diet might be helpful. So your fruits, your vegetables, your whole grains, your lean proteins, your healthy fats. Then we had Dr. J. Lee's research come out last year that suggested almost the opposite. These foods with higher glycemic index, think like French fries might be beneficial. So I often encourage pals to focus on a healthy diet and calorically dense foods. So foods that you get a lot of bang for buck. So eggs, cheese. I know nuts are a little bit harder to chew, but adding nut butter like peanut butter to oatmeal and milkshakes and smoothies, avocado or guacamole, whole fat dairy, hummus. Sometimes it's easier to drink your calories. So to drink those high calorie drinks that we talked about, smoothies, juice. But I say at the end of the day, if you need an extra scoop of ice cream to get you to those calorie goals, do whatever it takes.
Yep.
But know that, especially if you're going to a clinic, you have all these other healthcare providers there. So, and So if you have swallowing difficulties, talk with your speech language pathologist. If you have leg or arm weakness, it's hard for you to grocery shop, it's hard for you to cook or feed yourself, talk to your physical or occupational therapist, your physiatrist, if you have those. Um, if breathing is an issue to you and you're putting a lot of calories, just struggling with breathing every day, talk to a respiratory therapist or pulmonologist. If it's a matter of your appetite, you're just not hungry, discuss with a neurologist or other provider if an appetite stimulant medication is appropriate for you. And there's also the option of a feeding tube, which is a very personal and individual decision. There's so much that goes into feeding tubes, so we're going to have a whole other podcast that discuss
Yep.
about feeding tubes.
So that will be part 2. Join us and learn all about feeding tubes on part 2.
That was a great part 1 to this podcast. Thank you to Alisa and Stephanie for your valuable insights. I know this information will be very important to the ALS community. As always, if you're interested in learning more about ALS, our care services, and research, please follow us on social media and visit our website, alsmidatlantic.org, where you can learn about events, you can learn about how to connect with our social workers and experts like Alisa, and you can, of course, donate and volunteer. Now, on to part 2.
Hi, I'm Alisa Brownlee with ALS United Mid-Atlantic, and I am here with my colleague from the Jefferson Weinberg ALS Center in Philadelphia, Stephanie Dobak, and this is part 2 of our discussion about dietary issues when it relates to somebody diagnosed with ALS. The first part of our discussion talked about the calorie maintenance and why it's important, how long it should take to eat a meal. And now we're going to go into what happens if you can't maintain your calorie intake. What happens if it's taking you 2 hours to eat a meal? What is the next step? And I understand it's feeding tube, correct? Yeah. So can you tell people, I think there's a lot of misnomers about feeding tubes, like it'll impede a person or they don't understand anything about it and they're afraid of it, but they don't know anything about it. So if you can give us an overview of what it is.
Yeah, absolutely. So, and these are hard discussions, but generally, like a feeding tube is a tube that's inserted into the body and it can help you get in more calories. It can help you get in more hydration. You can even put medications through them. There are different types of tubes. So when I first start talking with pals about feeding tubes, many of them think it's this tube that's going to hang out of your mouth or your nose. It's going to be very visible. Know that these tubes do exist. They are usually used in the hospital for short-term use. We know, unfortunately, that ALS is a progressive disease, and the tube's going to be needed for a longer time. So we place tubes that surgically directly into the stomach. So yes, it is a surgery, but the tube itself is very discreet and it's hidden under the clothes, and nobody would really ever know that you had one. Like you mentioned, Alisa, that there's the stigma about feeding tubes and associating it with people in mentally cautious states or with dementia. Many of my pals have lived through those national legal cases that were broadcasted on their TVs about Kieran Quinlan and Nancy Cruzan, Terry Schiavo, these
Right, yeah.
really unfortunate women that were in these vegetative states with little to no quality of life, and they were kept alive by a feeding tube. So I always say that these feeding tubes look very different in pals. I have pals going out in the community, traveling, working, attending family events, all while having a feeding tube. So it really does look different than what we typically picture.
Can I get one anytime, or is there a time frame of when I can get a feeding tube?
Yeah, I mean, you could get one at any time. So some people choose to get it before they need it. But then some people, we have indications that, hey, we're going to bring up this conversation. Usually if you are losing weight, if you are getting dehydrated because it's a struggle to get liquids in, or you're losing a lot of liquids through saliva or drooling. If you're coughing or choking frequently with foods or liquids, if you're spending hours daily trying to get enough food or liquids in, like that's so stressful. And then, if medications are difficult to swallow, so knowing that a lot of pals take a lot of medications and supplements, that could be very time consuming. These are the indications of when you might need a feeding tube. A feeding tube is not for everyone.
Yep.
So
I
you
asked that.
have,
Yeah.
yeah, you have 100% choice in the matter. So our goal as healthcare providers is to provide you with the information, the pros, the cons, give you all the information to make an informed decision for yourself. We're not going to just leave you there high and dry. We're also going to partner with you in that decision-making process because we know it is a very difficult decision to make. We help you define what's important to you. What are your healthcare goals? And determining if a feeding tube is a good option and aligned with your goals. So know that at no point would I ever tell anybody that they need to get a tube if they don't want a tube. There have been instances where we have presented the option of a tube early in the disease process. A person might decline it. They say, I don't need it at this point. I'll think about when feel the need for it. Or no, I never want one. But then as the disease progresses, they might get to a point where they're in this late stage disease and they panic and they're like, hey, can I get a tube now? And we as a team discuss, that at these later disease stages, that tube might bring little benefit and might be a huge risk with the surgery and that unfortunately that the window has closed for those people and we just think it's too risky. But whether or not you decide to get a feeding tube, we know it's a hard decision. Again, no one envisions themselves getting a feeding tube. But we always put the pals in the driving seat and making that decision for themselves, and we're going to support you either way.
So you're going to get nutrition through the tube, but I also know people get hydration through the tube. And what I've heard is some people say, I cannot get water down, but I can still eat a little. So 2 questions. What goes through the tube? And if I can still eat a little, can I if I have a tube?
Yeah. So great question. So you can again use the tube for formula. So similar to those high calorie drinks that you might already be taking by mouth, to replace meals or supplement to make sure you get enough calories in. Some people opt to even make their own meals like smoothies or soups that go through the tube. So we just talk about how we don't clog the tube and get enough nutrients in, but no, that's an option that you can make your own meals. You can put water through the tube. So like you said, Alisa, a lot like swallowing difficulty usually starts with thin liquids like water. So sometimes it is very hard to get liquids in. They might be okay in maintaining their weight with the foods. So we might just use the tube to get water in and hydration. Medications go through the tube. So a lot of people like that. So either in liquid form or you can crush them into a powder, add them to some water, make a little slurry of it and flush them through the tube. So food, water, medications can all go through the tube. But to your question about can I still eat? So a lot of people are like, oh no, I don't want to because I still love eating. So yes, as long as swallowing is relatively safe and brings you pleasure, we don't want to take that from you. I always defer. I always say check in with your speech language pathologist for that. But many people opt to get the feeding tube before they need it. So if the swallowing function does get worse over time, again, you might use that tube, maybe even just once or twice a day to get formula in, but you're eating the rest of the day. Eventually, there is the point that the disease might progress to the point that you might not be able to swallow much at all, and you need that tube to get the majority of your nutrition and hydration in. But even if that's the case, if you still enjoy eating, even if you want like a bite or two of ice cream, for the most part, we're going to say, absolutely, we still want you to eat if that brings you joy.
So am I going to have to like carry an IV pole with me everywhere I go? How am I getting this nutrition?
Yeah, so I will say we leave that up to the pals, but we also come alongside them to work with them to see what might be good for their lifestyle. So I will say most people opt to administer the feeds through a syringe. So this is a fast way of doing it. It takes about 5 to 10 minutes per meal. It's portable, so you can just grab a container of formula, you can grab a syringe, and you can go out in your day, go to work, go out in the community, and administer that really quickly. Some people opt to have it go through a bag that's connected to an IV pole. So these are called gravity bags because the formula drips through the bag by gravity and into your stomach. So you can adjust the time. There's a little roller on the tubing, so you can have the container of formula go over at 10 minutes, over 30 minutes. But know that this is a less portable option. But it does go in slower. So if fast meals are a problem for you, that's an option. It also frees up the caregiver during the mealtime, which
Yeah.
I think is key. They can eat their meal, they can go about doing other things. But know that you are going to be connected to that bag, that pull 3 to 4 times a day for 10 to 30 minutes at a time. But the good thing is that, since most PALs in the US have Medicare, if they cover the formula, they're going to cover syringes or gravity bags, no question asked. And these supplies get shipped to your home through your insurance in a durable medical equipment company every month. But some people, even the gravity bags, that's too fast for them. They need to stretch the feeds over 8 to 12 hours a day or a night, whatever they choose for themselves. So this does mean if you are getting the feeds through a pump, that you are connected to that pump and to that pole for 8 to 12 hours a day. So it's not ideal, particularly for people who are more ambulatory and like to get out of the house. But for people that can only tolerate a small amount of volume feeds at one time, it's a great option. But again, coming back to Medicare, even though the syringes, the gravity bags are no problem, Medicare does require additional justification for the feeding pumps.
Okay. I think a lot of people are worried about any intervention that might be a burden on the caregiver, but this sounds like it's not a burden. It's really, if they're doing the syringe 5 to 10 minutes, or they're just hooking somebody up, it doesn't sound like it is a lot for the caregiver, correct?
Yeah, and I think that's a good point. That caregiver burden, we know it is
Yeah.
so high in this type of disease. But I will say from my experience in terms of education, that's where the burden lies with caregivers who are going to manage the tube. Because they already have so much on their plates. They are managing medication regimens. They are managing doctor's appointments. Many are bearing the financial burden if their loved one's no longer able to work. They are battling out with insurance for coverage. They are managing non-invasive ventilation. On top of all of this, they are dealing with the emotional toll of watching their loved ones suffer. So I know that the caregiver burden is so high in that population. We really do need to look out for our caregivers. So learning how to manage the tube and ensuring supplies come monthly to the home is one more thing for them to learn and manage. But I will say, from my experience, caregivers who have been spending hours with their loved one each day, feeding them, making them high calorie foods, if they're only able to take sips of liquid at a time, spending so much time getting pills in, these caregivers actually love the feeding tube because, like we said, it might be a meal over 5 to 10 minutes instead of 50 to 60 minutes. We can set up the gravity bag. You can eat alongside them, or you can do other tasks while it drips in over 10 to 30 minutes. So a feeding tube can really free up a caregiver in many ways and decrease that burden.
And from a psychological standpoint, watching the person you love try to eat and maybe choke, or just, you as a caregiver want to alleviate that. It's hard as a caregiver to watch somebody struggle so much.
Yeah, it's so stressful too.
Yeah. And one of the things that I hear or have heard throughout my long-term career here, most of the people that I meet, they have an idea of how they want any intervention. They go, I just want nature to take its course. So they're hesitant about the feeding tube, and they say, well, it'll keep me alive longer. Is that true?
Yeah. So, studies are really mixed on the survival benefit of feeding tubes in people with ALS. So some studies are suggesting, yes, it prolongs survival, and others are saying, no, it doesn't. So I think ultimately when I sit down with somebody and talk about a feeding tube, the question we're asking is, will a feeding tube maintain or improve your quality of life? So will I no longer be spending hours a day thinking about getting enough food and liquid in my mouth? Will this actually free me up to do things I really want to do? Will it free up my caregiver so they're not spending hours on food with me? Will I no longer have that anxiety of choking on meals or medications? And then I think we underestimate how inadequate nutrients can really drain your energy. So would you possibly feel better if you have enough nutrition and hydration and that correct amount of nutrients? But those are the more positive parts of the feeding tube. But there's other things to consider, that all surgeries come with a risk. the more that goes into the body, the more that's going to come out. So that might be more transfers to the bathroom or the commode. At times, the tube might malfunction, or the skin around the tube might become problematic. So we had to treat that. I would love to say that people automatically tolerate the formula that we order. Many times they do, but sometimes it's a troubleshooting and we had to try different formulas. So you had to deal with maybe some nausea or diarrhea as we find the formula that works for you. And then there's as is one more durable medical equipment or DME company that you're dealing with.
Yeah.
So you might have the stress of delayed shipments and all that other stuff. So there's definitely pros and cons outside of just thinking about survival.
And then what if somebody says, you know what, I don't want it anymore? Do they have that right to say, I'm done using it, correct?
Yeah, absolutely. So again, you don't even need to have to get a tube. We're always going to work with you to try to get the nutrition in. I think a lot of people are terrified of starving to death.
Yeah.
But the body is amazing at adapting. It decreases appetite. It decreases the thirst mechanisms. It has other mechanisms in place that you're not suffering in that way. But say that you do get the tube placed, it can be removed in any outpatient setting. It is a quick 2-minute procedure that they pull it out. It doesn't require anesthesia. It doesn't require surgery or going back to the operating room. But, however, again, since ALS is progressive, we know that the indication of why you needed the tube in the first place. So say you're having a lot of trouble with swallowing, that indication isn't going to go away.
Right.
But know that you can also choose to keep the tube in, but stop using the tube. And this is actually quite common in those last weeks of life. So the body starts shutting down. It causes the appetite to decrease. Food just doesn't digest as well. So many people in these later stages will keep the tube, but start declining tube feeds. If they're ordered 4 containers a day, they might be like, I only want 2 today. And
Okay.
you know that this is acceptable and perfectly normal, and often what we see at those last stages. But at the end of the day, it's your body, it's your life. We as healthcare providers are here to support you the best we can and come alongside you to help you get what you want for your care.
And when you're talking about, decreasing the amount of feeds and towards the end, normally, hopefully, hospice would be introduced too for comfort care.
Yes, absolutely.
Yeah.
So they can, have the medication, and you had what we call boots on the ground, because a lot of the time these clinics are every 3 months. We might see you earlier, but it's nice to have another agency that is managing your symptoms.
And that just brings up another point. Some people can enroll in hospice and have a feeding tube, right? Because it's not considered life extending. Is that right?
Yes, exactly.
Okay.
So hospice agencies get a dollar amount per day. So it does cut into that dollar amount every service that they provide. So providing the formulas, the syringes, they take over that when hospice comes on board. So know that a lot of hospice agencies are like, oh, we're going to try to change you to a cheaper formula. And so you might have to switch your formula, but they do provide it. There's also the Ole Foundation is a foundation focused on people that have feeding tubes or IV nutrition at home, and they have an equipment exchange program. So especially if you live in a city like Philadelphia, there are so many people that are like, hey, we have all these extra supplies, or we weaned off feeding tubes. We have all these syringes and formulas. You can just show up in a parking lot. I've done that. It seems a little sketchy, but it's perfectly okay. These people are the nicest people, and you can get supplies that way too. But yes, hospice should continue to supply you and support you on the feeds.
So our office does have an equipment exchange page on Facebook. If anybody listening to this or watching this would like it, please send me an email. It's Alisa, ALISA, and I will send you the Facebook link, because we do have a lot of people who put extra formula. I have 12 cases of formula that expires XYZ, and I live in Warminster, Pennsylvania, and you're right, people will just go and drive. So or sometimes it ends up at our office, and we'll get a general email. Hey, we have 6 cases of XYZ formula. Anybody who needs it? And then so the staff tries to identify who might need it. So yes, there are ways to get it. Especially, you're right, if hospice wants to change your formula and you're like, no, I really want to stay on it. So there are ways to get it. And I want to thank you so very much. This was so informative, and I hope that any person with ALS can at least get hooked up with a dietitian once, twice, even if you can't get to them, maybe they can do telehealth, right? Yep. So if you are interested in getting more information, send an email to me and I'll ask Stephanie for any handouts. You have handouts, right, that you give people? Yeah.
Lots of handouts.
Lots of handouts. So thank you so very much. And I appreciate your time and expertise.
Oh, thanks so much for having me. I'm so passionate about this topic, and I'm here to help in any
Okay.
way you need.
Thank you.
Thank you again to Alisa and Stephanie for a fantastic conversation. I hope you all liked this special edition of our ALS United Mid-Atlantic Goals podcast. Again, please subscribe and like for more information on the podcast. Follow us on YouTube and Spotify and iTunes, where you can get updates every week from ALS United Mid-Atlantic. If you'd like to join our events, or you'd like to donate or volunteer, you can visit us at www.alsmidatlantic.org. Together, we will end ALS.